Hi everyone, my name is Emily Crawford and I'm a second year internal medicine resident at Beth Israel Deaconess Medical Center. I'm joined by Dr. Jason Mados for a discussion of narrow complex tachycardias as part of our EKG curriculum this year. And this will be a two-part session, so stay tuned for part 2 coming up next month as well. Our objectives for this session will be to define narrow complex tachycardia, to describe a systematic approach to narrow complex tachycardia, to be able to recognize 3 common narrow complex tachycardias on EKG, and lastly, to discuss the pathophysiology and management of 3 common narrow complex tachycardias. All right, so getting started with defining narrow complex tachycardia, it's almost as simple as it seems. We have our 2 parts, our tachycardia defined as heart rate over 100, and narrow complex referring to the QRS complex being less than 120 milliseconds. Now, this is often referred to as supraventricular tachycardia, which for the most part is true, as the etiologies of these tachycardias, which we'll go through, are most commonly the SA node, the AV node, or atrial tissue itself. But there are some of the tachycardias, more specifically reentrant tachycardias, that are due to accessory pathways, which are not technically anatomically above the AV node or the ventricles themselves. And so while you'll hear these terms used relatively interchangeably, for the most of the rest of the session, we will refer to these rhythms as narrow complex tachycardias. So next we'll go through a systematic approach of narrow complex tachycardias. And I just want to give a caveat that there are many different algorithms that you will see out there, and this is just one that's derived from the AHA guideline on supraventricular tachycardia. And I think the big takeaway here will be that it's important to have a diagnostic approach that works well for you and makes sense, and also have in the back of your head that sometimes you're going to need advanced maneuvers to be able to even differentiate these rhythms, and I think that's something we'll comment on throughout this session. But to begin, we have our narrow complex tachycardia, and the first question we ask ourselves is the rhythm regular or irregular? And if it's irregular, there are 3 main buckets of diagnoses to be thinking about, which include atrial fibrillation, atrial flutter with variable block, and multifocal atrial tachycardia. If the rhythm is regular, the next question we are going to ask ourselves is, are there flutter waves visible? And if there are, then we're thinking about atrial flutter. And if there are not, we are going to next look at P waves and look at the RP interval. And the RP interval I'll get into in just a moment. But if we have a long RP interval, we're thinking about sinus tachycardia, atrial tachycardia, and atypical reentrant tachycardias. And if we have a short RP interval, we're thinking along the lines of typical AV reentrant tachycardia and typical AV nodal reentrant tachycardia. And so these rhythms we are going to be reviewing today, and these rhythms we'll be reviewing in our upcoming session. As I mentioned, this is part 1 of 2, and we'll go through those
in our next session.
Yeah, just go back one second. Only that yellow, so everything you highlight in yellow, these are very, and you're going to go through the pathophysiology of these, but the reason why they're so regular is they have a very clear fixed circuit, and all of them have like a clear circuit that's driving this for the most part. And so they're really regular. And the only time where you may run into some issues is if something is very, very fast, like greater than 160 beats a minute. Sometimes it's hard to differentiate regularity from irregularity. But yes, most of these have a very regular fixed circuit.
Awesome. Yeah, that's super helpful to help frame sort of why they are regular and how we can think about these as we go through them. So getting into the RP interval, I think this was something that was a little bit more new to me as I got further along into residency. But here we have just an image of the PQRST complex, which is sort of a callback from Tuba's initial EKG basics session. where she walked us through the various segments of this. But the RP interval is essentially the interval between our R, which is our ventricular depolarization, and our P, which is our atrial depolarization. So if we sort of superimpose the next beat here, you'll see the RP interval sort of marked out here. And again, this represents the time between the ventricle and the atria depolarizing. And so we define a short RP interval as being shorter than the PR interval, and a long RP interval being greater than the PR interval. So this is one way that we can help discern different types of narrow complex tachycardias, though as we go along here, and I'll sort of emphasize throughout, while this is a helpful way to try to differentiate these rhythms, it can often be quite hard to do this when the rate is incredibly fast, and oftentimes you really need a more intense sort of EP mapping study in order to actually be able to discern some of these rhythms. So it's helpful to look at it, and if you can see it, it will be a good part of your diagnostic algorithm, as we just outlined, but isn't always going to be the shoe-in to help you discern what rhythm is going on.
And when you have a short RP interval, what makes it short is the timing of when a ventricle is depolarized and an atrium is depolarized. So when you see a short RP interval, well, let's start with a long RP interval. It's the most often long RP interval you see is what you see every day, which is the P happens and then the QRS, and the next P doesn't happen for a while. But in a short RP interval, you can imagine that that would happen when either the ventricle and atria are depolarizing simultaneously or the atrium is depolarizing just after the ventricle. And we'll go over some examples of how that could happen.
Perfect. So here is our first EKG that we'll go over together. So just take a second to pause the video and go through sort of your typical systematic approach to reading an EKG, and then we'll go through it together. All right, so taking a look here, we can see that immediately right off the bat, you're looking at a tachycardic rate here. Looks like it's just about right around 150 or so, and it looks very regular. And when you look at the QRS complex, it is narrow, so you know you're in your narrow complex sort of algorithm here. And the next thing to do is sort of looking at our P waves and looking for P waves, which can definitely be hard. They're difficult to discern, but what I'll point out here is that you can see a little blip here in V1, and then when you zoom in closer at our rhythm strip and look very close here at the QRS complex, you actually see a P wave sort of very subtly here and buried within the QRS. And then again, looking to just sort of try to ascertain this RP interval, we can see that it's quite short. And as Dr. Matos was just commenting on, sort of we are recognizing that the atria is contracting sort of right after the ventricle is. And so seeing this, we can tell that this is sort of very typical for an AV nodal reentrant tachycardia. And
Can I just emphasize one thing about these P waves? Because you
yeah.
mentioned lead 2 and V1, which are two of the best places to find P waves.
Mhm.
But you may be watching this and say to yourself, okay, well, I saw that Emily pointed them out, but how can I do this by myself? Um, Two things. One, it's very helpful to have a baseline ECG. For example, that little red circle in lead V1, that little hump thing that she has highlighted. You can look at a baseline ECG, and that little notching at the end of the QRS when the patient's in sinus rhythm should not be there. And then two, that little subtle, what almost looks like an S wave at the end of the QRS in lead 2 should not be there. And anything in the ST segment or repolarization should be a smooth, low amplitude process, and there shouldn't be any speed bumps. So any speed bumps in the ST segment, even if they're at the very beginning of the ST segment, should be a clue that there's atrial activity buried in there.
Awesome. Yeah, that's super, super helpful to point out here. And so when we are thinking about the pathophysiology of AVNRT, it's really underlyingly, it's a re-entry circuit that's within the AV node, and we'll talk a little bit about that in the next couple of slides. But this is often initiated by a premature atrial contraction, and again, we'll review this sort of in the next slide or two. But when you're looking at telemetry, or even if you happen to catch it on a 12 lead, you'll often see that this gets kicked off by a premature atrial beat. And again, just highlighting that the EKG findings are that the P waves sometimes cannot even be discerned, or if they are seen, they're often buried within the QRS complex, as Jason just sort of outlined for us. And then again, characterized by a short RP. And then from a treatment standpoint, there are a few different tools we have in our bucket for managing AVNRT acutely. And these include vagal maneuvers, adenosine, some rate control agents, being beta blockade or calcium channel blockers, and then synchronized cardioversion if unstable. And again, we'll dive a little bit deeper into that as well. But in order to understand the pathophysiology of AVNRT, it's important to sort of remember what our normal AV node conduction looks like. And so, we have a beat coming from the sinus node, and typically it travels down through the AV node to our His-Purkinje system via what we call the fast pathway, which is characterized by fast conduction and slow repolarization. But what is also going on sort of simultaneously is we have electrical activity that's still traveling within the AV node through what we call the slow pathway, which is characterized by slow conduction but fast repolarization. And so even though we also have electrical activity traveling down this pathway, it often gets halted here because we, already are fastly conducting here, and this tissue is already repolarizing, so it's not going any further.
I'll just add that, not everybody has a fast and slow pathway that conduct. Probably somewhere, nobody really knows the number, but somewhere between 10 and 35% of individuals have both this fast and slow path. Everyone has a fast pathway, but this extra slow pathway that functions is probably somewhere between 10 and 35% of the population.
Perfect. Yes, definitely important to recall there. And then so when, how AVNRT kicks off is, so, on the left here, we have that mechanism we were just sort of describing of a normal sinus beats, but then you have a premature atrial beat, which comes down and enters the AV node, and it tries to go down the fast pathway, but because this fast pathway is still repolarizing, remember it repolarizes slowly, what ends up happening is it can't travel down the fast pathway, so instead it travels down the slow pathway, and sort of it slowly travels down here. And by the time it gets to the bottom, the fast pathway has already repolarized, so it takes advantage. And not only does it just conduct down to the ventricle, but it also then continues upwards, sort of up the fast pathway, and enters a re-entrant circuit here, where it is conducting, sort of up to the atria, and then, quickly back into the circuit, down to the ventricle, and you end up with a re-entrant circuit. And sort of this is reflective of, as we were mentioning earlier, about why this is such a regular rhythm, and this is reflected in, and this is the circuit within the AV node itself.
I think what's important, it's really nice in this slide, is that the rhythm initiates, you see here in the second part, with this very long PR interval, reflected by going down the slow pathway. So a lot of times people try to review telemetry and try to suss out which type of rhythm it is. But the important thing is one of the most important thing is to review the initiation. And when you see this characteristic initiation with a PAC and a long PR interval, followed by this very regular fast rhythm, that is quite characteristic of AVNR, of typical AVNRT.
Perfect. And so, stepping a little bit into the management of AVNRT, we mentioned vagal maneuvers. And so our goal here is to increase the parasympathetic tone to slow conduction at the AV node. And you may have seen this done before, but some common examples include the Valsalva maneuvers as well as carotid sinus massage. So, some examples of the Valsalva maneuver here you see pictured, you ask your patient to try to blow into a syringe, trying to have them sort of bear down as ways of trying to increase that parasympathetic tone. And then carotid sinus massage is another option to try. And the important thing here is to ensure that there's no history of significant carotid stenosis. Take a listen with the stethoscope, making sure you're not hearing a bruit, because there's a theoretical risk of dislodging plaque and causing, stroke or TIA symptoms here. So those are just some sort of clinical important things to do related to these maneuvers. And it requires a lot of pressure to actually be able to successfully do a carotid sinus massage. The enough force to actually dent a tennis ball, which I remember when I learned that last year, was sort of shocking how much force was really needed. And so if you're doing any vagal maneuvers and some of the other things we'll talk about, important to have a rhythm strip running while conducting these maneuvers, because just as Jason was saying, it's really helpful to try to see the initiation. It's also quite helpful to see how it terminates as well.
Yeah, just to add that you don't actually need to do any type of massaging whatsoever. You just press very hard.
Pressing. Okay, that's great. That's actually really helpful to just apply force, and that should be enough if
And
you feel
warn
it.
the patient ahead of time that it's going to hurt and they're going to feel funny for a few seconds.
Great. And then next we can talk about adenosine, which similarly we should be warning our patients about. But the mechanism here, adenosine acts at a few different receptors, but it slows conduction at the AV node, which is referred to as negative dromotropy, and decreases the heart rate, which is referred to as negative chronotropy. But of note, it also has some vasodilatory effects on vascular smooth muscle. So when we're thinking about who we should be considering this for and who we should, not be considering this for, if a patient has a history of significant coronary artery disease, it would definitely avoid using adenosine, as it can result in a coronary steal phenomenon, as well as some pretty severe ventricular arrhythmias. And then patients with severe lung disease that can actually be bronchoconstricting. So would also be, a group of patients that you would not want to be using adenosine in. And then in terms of some things, rules or pearls about administering it, you always want to have the pads on the patient. Again, this sort of gets to the fact that if they were to develop a ventricular arrhythmia, you would immediately want to be able to intervene, running that rhythm strip to be able to see its termination. And then the half-life of adenosine is incredibly short. And so making sure that you, and have nursing as well, push and flush this very quickly, as well as, raising the arm up so that it gets to the heart before the half-life has sort of expired. And then from just a dosing standpoint, you could trial 6 milligrams first and then, go to 12 milligrams.
Yeah, I would say two things. One, it slows conduction to the AV node. I mean, basically shuts it off. It's kind of like a reset button for the AV node. And the second thing, even more so than the carotid sinus pressure, is warning the patient what's about to happen, because they literally feel like the world's caving in on them and they're about to die, and because it literally their heart stops briefly. And so it can be very disconcerting to them. So to give them a heads up that they may feel really horrible for a few seconds, but it's going to go away quickly.
Great, thank you. All right, so here is our next EKG that we'll review. So again, just take a second to pause the video and go through what you think is going on here. All right, so just like our prior EKG, going through this systematically here, looking at the rate, we see it's immediately tachycardic, even more so than our last patient, around like 170, 180 or so. And we see that it's regular in terms of the rhythm, and we have a narrow complex. So again, we're in our narrow complex algorithm here and taking a look once again for P waves. And we're using looking at V1 and V2, or sorry, lead 2 here. If we zoom in, we can see this notch here that's representative of P waves buried here or coming just after the QRS complex. And taking a look, we have again a short RP interval, not quite as short as our prior. Looks like it's over 70 milliseconds, and this is characteristic of AV reentrant tachycardia here. So thinking about our pathophysiology for this tachycardia, again, we have a re-entry circuit, but this time it's created by an accessory pathway and the AV node, as opposed to our AVNRT, which was within the AV node. Here we have a circuit that involves the AV node, but does not occur only within the AV node itself. It's involving an accessory pathway, and that's sort of a key difference here. Again, this is typically triggered by a premature ventricular beat that travels along the accessory pathway, or a premature atrial beat as well. And the EKG findings, just as we've sort of already touched on, are that we typically have the P waves that sort of immediately follow the QRS complex, and again, characterized by a short RP. Importantly, there are two sort of distinct types of AVRT. The first is orthodromic, which is where the circuit is traveling antegrade down the AV node, as opposed to the antidromic, where the circuit is actually traveling retrograde up the AV node. And our treatment categories are the same as AVNRT. And I think that's an important, point to make here, is that, as we've commented on, sometimes we're going to have difficulty actually discerning some of these rhythms from each other. But the management is actually going to be the same for most of these things, which is just important to be thinking about, even from a clinical standpoint.
I'll just highlight antidromic, since it's traveling retrograde up the AV node, that it's probably going down the accessory pathway. And if it's going down the accessory pathway, it's typically a wider QRS because it's not engaging the AV nodal pathway. And so typically antidromic AVRT is a wide complex tachycardia.
Yes, thank you. Thank you so much, Jason. And here, just in case you have
Oh, there it is. Yeah.
yeah, perfect. Just in case these things I feel like can be really hard to visualize without looking directly, sort of at a figure here. And so this is sort of a manifestation of what the orthodromic circuit could look like. So again, that's where the accessory pathway, you're sort of coming up here and down the AV node in this direction. And so you have the narrow QRS complex, as opposed to in the antidromic, as Jason was just mentioning, where we're coming up through the AV node from the ventricle. It typically manifests as a wide QRS here with a delta wave.
And that RP interval is a little longer in AVRT versus AVNRT, because remember, AVNRT, we're shooting right back up that fast pathway. So it's right on top of the QRS. But since it's just a few milliseconds slower going back up through that bypass tract, and that's why there's a little bit more space in that RP interval.
Awesome. Yeah, that's a really helpful point to be thinking about. It's sort of anatomically exactly where we are. All right, so this is our last EKG here. So same as before, just go ahead and pause and take a look at what you think may be going on. All right. So just as before, we have someone going at a rate of about 150 beats per minute or so, and looks pretty regular, looks like a narrow QRS. And so we start sort of hunting for our P waves, and looking here in lead 2, we see what looks like potentially some P waves, but with an abnormal axis, right? There's down in 2. And we sort of look in AVR, we see those similar notches in an upwards direction. So again, not the typical axis we're used to. And looking closely just at our RP interval, as we have been with our prior EKGs, we see that this is characterized by a longer RP. And so putting these features together, this is consistent with an atrial tachycardia. And so again, thinking about the pathophysiology, atrial tachycardia is caused by ectopy within the atrium that's outside of the SA node. And this can be either focal or multifocal, with focal being the result of like one single point of ectopy with a consistent morphology, as opposed to multifocal, where there's several points of ectopy with variable morphologies that are resulting in the atrial tachycardia. And this is typically triggered by an underlying medical, process going on, things like infections, pulmonary disease, classically as well. And as we've just looked at here, the typical EKG findings are, that you can see P waves clearly, but they have an abnormal access or an abnormal morphology as well. And then the longer RP interval, again, when you're thinking about the timing of the atria and ventricular depolarizing there as well. And
I
then
just
the
want to add one more trigger, sorry, because we live in a world where lots of patients are getting ablations,
Mhm.
and ablations, while can be very helpful, can unfortunately the scar from ablation or acutely more the edema from an ablation can serve as an arrhythmianitis itself. And so sometimes there can be iatrogenic when you're doing a pulmonary vein isolation for atrial fibrillation, for example, that can serve even sometimes just temporarily as a nidus for atrial tachycardia.
So that's really helpful to keep in mind and be on the lookout for as well. And then, from a management standpoint, as much as possible, sort of treating the underlying problem, and then if needed, can also reach for beta blockers or calcium channel blockers as well. All right, so just to review some pearls and really key takeaways, I think, for narrow complex tachycardias. First, from just a diagnostic standpoint, I think as we've been mentioning, is really using telemetry to see how the arrhythmia began and looking for those features, whether it was premature atrial or ventricular beats, whether the arrhythmia began, very suddenly as opposed to sort of an incremental, steady increase in heart rate, looking at those intervals, looking for the preceding long PR to help figure out what sort of went on and contributed to the arrhythmia itself. Um, remembering having an algorithm or at least a way to approach these different tachycardias and knowing how to differentiate between them, and whatever algorithm you end up using or way you think about them, just having a structured approach to helping diagnose which tachycardia you're sort of dealing with in front of you. But then simultaneously keeping in the back of your mind that it can be really hard to, especially depending on how fast the rates are, to really differentiate the underlying etiology, and knowing that you may need to end up sending the patient for a formal, EP study as well. And then from a management standpoint, as we have looked at here in the acute setting, of course, thinking about your patient being hemodynamically stable or unstable. And if they're stable, we talked about trialing vagal maneuvers, considering the use of rate control agents such as beta blockers or calcium channel blockers, and then discussing the use of adenosine and when and who to think about using it and not using it. And then, of course, for our patients who are hemodynamically unstable, providing synchronized cardioversion. And then just long-term for these patients, getting them to an EP mapping study and consideration for ablation, depending on the underlying etiology that is identified, can be helpful as well.
Yeah, just that sudden versus incremental at the top. So, a gradual increase in heart rate traditionally is more of a sinus tachycardia versus if you see that in those general time graphs of the heart rate, those sudden jumps would be usually one of these SVTs that we've talked about. And yeah, I agree with you completely, Emily. Like it's hard for you to say, oh, the RP interval was 40 milliseconds versus 60 milliseconds, so I know what it is. Unfortunately, that's not the case, but especially when the SVT is slower than 150, 160, it can be very helpful in helping you figure out what it is.
Great. All right, and then we just have a few practice EKGs to wrap up with here. So here's the first one, and just like before, you can go ahead and pause the video to take a look. All right, and just like before, we're seeing here a regular tachycardia. It's narrow complex, and as we're looking for our P waves, looking in lead 2 here and in AVR, we're seeing P waves upright in 2 and down in AVR. And taking a look, we see, P waves before every QRS. And this is actually just a sinus tachycardia, and I wanted to include this here because, technically sinus tachycardia is a narrow complex tachycardia, and so always being sure to think about this as well when you're just quickly reviewing an EKG for, the patient you're getting called to for reviewing their tachycardia. All right, next one here, same as before, just go ahead and pause. Okay, so taking a look at this EKG, as we're looking at the rhythm strip at the bottom here, we see maybe it initially looks somewhat regular, but then as we're looking a little bit closer, we're seeing that this rhythm here, it's tachycardic, but it's actually irregular. And so when you're taking a look and trying to find the P waves here, you're seeing what looks like P waves before each QRS, but the P waves are looking different from one another. I've circled a few here that appear to be P waves but have different morphologies. And so thinking about what could be going on here, this is actually a multifocal atrial tachycardia. And so just like we had talked about a little bit earlier, this is where we're having multiple points of ectopy within the atria that are then conducting down and resulting in tachycardia. And so that's what results in each of these P waves is coming from a different ectopic focus within the atrium itself. All right, and then our last one here, same as before, just go ahead and pause. Okay, and so we're back to a tachycardic regular rhythm here that looks narrow complex, and so we're looking for our P waves, and if we're looking into, we're seeing that there's some areas here that look like they're not quite as smooth. We think we see some notching here, and these are actually P waves here, and then and V1, you're sort of seeing the same. We're seeing these small notches there, and if we look really closely, we're definitely seeing that this is an incredibly sort of short RP interval when the ventricle and atria are contracting just very close to one another. And this is consistent with a very classic AVNRT here. All right, so here are just some references for today's session, and just want to thank you all for joining us for the first of 2 parts for narrow complex tachycardia. So next month we'll have part 2 where we'll be going through atrial fibrillation and atrial flutter.